now let me introduce Kira Tosberg, who is our board member and also working from the German Coalition for Patient Safety. And she will be moderating the session about training and simulation that is entitled Using Innovative Technology to Empower Caregivers and Patients to Improve Patient Safety and Outcomes. Please, Kira, the floor is yours.
Thank you. Hello, everyone. Welcome to our next panel. I think we have a very nice structure when it comes to what we just discussed in the panel before this one, so I think we can connect on a lot of the points that we already brought up in the course of the discussion of this panel. So today we'll explore how technologies like simulation, virtual reality, a term that is thrown around a lot, and video platforms can be used to create a safer healthcare system. We'll start with a presentation by Monica. Maybe come up here. Monica is working with Relyens. Sorry, I'm probably mispronouncing a lot of things, both in Spanish, and you'll also see there will be some tricky English words in some of the roles that are being filled. So Monica's background is that she holds a degree in pharmacy and a master's in health management and administration. She is a partner with the Asociación Madrileña de Calidad Assistencial. Yeah, she will probably tell you what it's actually called. Short AMCA, so that's what I'm going to use from now on. And she has been a long-time collaborator with SECA. Currently, she leads health risk management at Relyens, and she is working with patient safety quality improvement projects and collaborating with healthcare teams across both public and private hospitals. Monica, thank you for giving us a keynote as a speaker, and go ahead.
Thank you. En primer lugar, en mi nombre y en nombre de Relyens, quisiera agradecer a la organización la invitación a participar en esta conferencia. Nos complace mucho compartir reflexiones y contenidos relacionados con la seguridad del paciente y la gestión de riesgos. Está en el ADN,
which is in the DNA and the philosophy of our activity. Relyens is much more than just a simple insurance company. We're a risk management agent. We want to control and prevent and ensure risks in order to protect strongly the territorial and health agents in Europe. Next to us, we innovate in order to guarantee the service that is of interest for everybody and that we want to keep safer and safer every time. In 2019, we became more than 90,000 employees, and we're present in 4 countries, France, Italy, Germany, and Spain, in 9 locations. And our European dimension allows us to have an enriched challenge of the challenges of our ecosystems and inspires our best practices. We support health agents and social health in the providing of their services and in the safety of patients and residents also. We have almost 100 years of experience as an insurance company, and we're experts in risks that healthcare professionals and authorities face. Relyens has become a deep transformation of our model, growing in the risk value chain, and we ensure upwards the claims. And this is a transformation that we started some years ago, and we are focusing the risk from the risk management point of view. It is a singular approach. It is a powerful team that combines experience, technical, commercial, and field experience. In Relyens, we have a wide range of skills. We have expert doctors expert witnesses, data engineers, lawyers, insurance subscribers, risk managers, legal experts, psychologists, and so on. Our teams act at all levels, and we want to be as close to our customers who are insured and our partners, working next to them so that we have the most adequate situation for different situations. Our supply is focused on three main areas: human risks, that is to say, improving the life quality and the working conditions and the attractiveness of the work center as a company that employs; technological risk, protecting the integrity of the devices that are connected and the computer systems of that medical center; and thirdly, the medical risk, in order to optimize the medical care that we offer and to protecting the medical centers and professionals in their practices. I'm now going to tell you about some data that we have about claims. Our European approach gives us a wide experience, not only in one health sector nationally, but also in the regions, which gives us a global experience so that we can apply strategies and tools that have been tested in other countries also. In the last 20 years, Relyens has registered 327,000 claims, 46% of which have to do with body damages. In Spain and Italy, the claims of body damages are larger than those of material damages as compared to France and Germany, and the distribution is different due to the differences also in the franchise rates in between different countries. As the franchise rate of the civil responsibility is larger in Italy and Spain, the low-level or low-value material damages are rarely claimed. The claims of body injuries notified in 2022 happened especially in surgery, 35% of these claims, 14% in medicine, gynecology and obstetrics, 13%. Amongst the surgical specialties, orthopedic surgery is number one, 14% of the claims, followed by digestive surgery, 7%, and plastic surgery, 6%. The medical specialties are divided into two categories: the general medicine, GP, 9% of the claims tend to be provided in primary care centers, and internal medicine, 5%, that tends to be given in hospitals. As I told you, when we look at the economic cost and the severity of the impact of the victim, the order of the specialties changes. The specialty of obstetrics and gynecology generates the most costly claims, even if it only represents 13% of the claims in volume, but they represent 18% of the total payments. In France, obstetrics become number two in terms of importance because of the consequences it has for the newborn after the incidents in the delivery. Now let's talk about reasons and causes of the claims. Mistakes related to patient care represent 38% of the claims that we manage. This term includes mistakes in the services we provide, 20%, mistakes in the surveillance, 8%, and delay in treatment, 6%, and neglects, 4%. Diagnosis errors represent 1/4 of the claims, 23%, as we said at the beginning of the lecture. This number seems high, especially if you compare that to the data that we have drafted in Relyens France, where the percentage is 9.8%, where the number is even larger in GP, where we get to 44% of the claims. Claims related to surgical techniques and the inadequate results represent 17% of all of the claims. These numbers grow up to 28% if we're talking about orthopedic surgery and traumatology, and 24% if we're talking about digestive surgery, but 60% if we're talking about repairing and plastic surgery. If we're talking about claims related to medical legal issues, such as lack of information to the patient, non-informed consent, that represents 7% of all of the claims, a number that is triple than that of what we observe in France. And that confirms that we need to continue working on strengthening the correct use of the informed consent and what is documented in the medical histories. The infections, complications are scarce in Spain. They only represent 3% of the claims. I'm talking about the claims that we manage, obviously, as compared to 13% registered in France, especially orthopedic surgery and trauma surgery. The specific pros for different disciplines reflect also an impact on the national projects such as zero surgical infection that has been mentioned earlier and that are special for special teams. Finally, we have mistakes or errors related to medication that represent a lot, although they only represent 2% of the claims. That is to say, people don't tend to file a complaint because of this. If we just want to talk about the events, never events. That means that when we forget foreign bodies, that's the most often events in both countries, and we can avoid them if we just check the checklist. I'm now going to talk about the technology. Insurance is the main activity that we started with, and it is a pillar in our business model nowadays. But some years ago, our group decided to transform our culture, organization, and technology with data and AI. And we focused on risk as the center of our strategy, and we contributed digital solutions trying to reduce the risk into different areas where there's more claims. That to us is the surgical block and intensive care units. Care Syntax is an innovative company with a headquarters in Berlin that was founded in 2013. We've signed an alliance with it as a partner. It is a platform to manage videos. It's agnostic. It can be installed in the cloud or locally in the hospitals. What does this technology contribute to the surgical environment? Well, the proposal of Relyens with this platform is not just giving a technological solution, but rather supporting in an integral way the customers in three main areas: preventing and reducing the risks associated to surgery, allowing for the notification of adverse events from the operating theater, and with videos we can improve the efficiency of the surgical block in order to manage the data of the OR. It improves the practices of the professionals, and Jennifer is going to tell you later. We video record the surgeries and we assess the technical and non-technical skills of the professionals during the surgery, which allows you to use it in order to train and in order for the professional to self-assess himself. As part of the most important functionalities, the solutions allow to collect information with the devices that are used in an operating room, to use the information that is collected for the clinical records, to strengthen the safety of the surgeries in the different phases of the surgery using checklists and notification of incidents from the operating room. It improves the practices. It allows to make comments, to analyze the videos of the surgeries, to give training, to share experiences, even in a remote way, what we call telesurgery. It allows us to manage the information with KPIs, which are operative and clinical. Relyens' offer is a singular offer in the sense that we have strategic projects that give support to the management of the organization, to change management, to integration of technology. It is a model which is economic and it's based on subscription. It allows for co-creation and it allows for a multidisciplinary approach. For 2021, we want to become a mutual company orchestrating insurance, prevention, and managing medical solutions, including cyber risk and risks associated to human resources in Europe. That's our mission for this year. Thank you.
Thank you, Monica. Thank you for both giving us an overview of the situation with risk management and showing us what you are currently working on. We'll hear more about a specific project of yours in the panel discussion itself. So before we do that, we will have to introduce the rest of our panelists. I think some are still getting their microphones, so there's a little bit of a delay, but I will start introducing them. Is the right presentation on? I don't know, where's the clicky thing? Do you have it? Ah, you saw it, okay. No, don't worry, okay. No, oh, too far. Let's go back. Okay, perfect. Okay, so I will start with introducing Carolina. Yep. Carolina Mudarra Reche, is an attending physician in the intensive care medicine service at Hospital Universitario 12 de Octubre in Madrid. Yeah, perfect. Thank you. It won't be the last time, so if we cheer every time, it's going to take a while. She is focusing on trauma and emergency ICU care. As a member of the video recording group for initial trauma care, Carolina provides valuable insights on using video as a tool for improving trauma response and patient outcomes. So Carolina, come and join us here. Next up, it's José. José Ferrer Costa, yeah, I hope I pronounced that correctly. José is a family medicine doctor and project manager in the innovation department at, you already said it earlier, and I'm not going to say it in the same way, Badalona Serveis Assistencials. Yeah, it's very close, in Barcelona. He specializes in the integration of virtual reality and immersive technologies, working to bring these tools into healthcare settings to advance training and enhance the patient care experience. Thank you, José, for being here with us. Next up is Deptº. Deptº Cartaxo Sintra is a critical care registered nurse at Hospital Clinic. The words that are closest to English are the most difficult, actually, in knowing how to say them, but in Barcelona. And he serves on the executive committee of the Society for Simulation in Europe, short SESIM, as treasurer. He is passionate about the role of simulation in healthcare and dedicated to connecting clinical simulation with practical care, research, and education to improve patient safety. Thank you for being here. And then the last member of our panel is going to be Jennifer Knepper. It's actually a German name. It is, so I can say it actually perfectly. Jennifer is a medical doctor and specialist, and this is the tricky part because she created the one moment where I really don't know how to pronounce the word in English. She's a specialist in otolaryngology. Yes?
Ear, nose, and throat surgery.
Yeah, exactly. With a master's in health economics and public management. She's a key account manager at Relyens Spain. And Jennifer combines her medical expertise with a focus on risk management, collaborating with teams to tailor solutions that align with the unique needs of her healthcare clients. So we already heard a little bit about your work, but you will tell us more in detail how that's actually going to turn out. So I'm going to sit in the middle of everyone. And to keep everyone on their toes, I changed the structure that we talked about in advance, so everyone has to be listening very carefully. I would like to start with the concept of simulation itself, because we just talked about, we just heard about risk management and we heard about certain solutions, but let's take a step back again and see what potential applications it has and how that can impact patient safety directly positively. So, Deptº, when considering a broad concept of simulation, where can it be applied and what impact might it have on patient safety?
Thank you for the question. Simulation is quite complex nowadays to tell and describe what it is. Some people, they think it's probably a technique. Other people think that is a strategy. We think nowadays that we are reaching another phase which simulation can be a methodology that we can apply in different fields. We can apply it on our institutions, we can apply in universities, we can try to keep the education of our professionals through simulation. So it's a quite broad concept, but usually we just have like a narrow vision of what simulation can be. And instead of having this disruptive image about simulation, which is a mannequin with a student and someone that is trying to interact and act a clinical situation through a mannequin, simulation can be more than that. Simulation can be part of our ecosystem inside of our healthcare institutions, and they can help a lot, not only the healthcare professionals, but also the patients, because we can do simulation with patients. So I think it's a really broad concept, and nowadays we don't have a clear idea about the impact that it can have, but it can actually help us a lot. And that's why I brought you this slide, like in clinical simulation, to err is a gift. Every single time we do a mistake in our clinical simulation settings, it's a gift to our patients, because this will save lives. Every time we do a mistake in clinical simulation, we are reducing the fact that this same mistake will happen at the clinical field, with the patient, with their families, with healthcare professionals involved as second victims of these mistakes. So we need to twist a little bit of our vision what is clinical simulation, and probably see a broader little bit more the concept, and probably integrate the patients on this ecosystem as well. So I think it could be a good way to it.
Mm-hmm. And I know that like sesame, I think most of us have heard it. I don't know how you pronounce it. Do you say
sesame?
Sesame,
Sesame,
of course. Sesame.
Sesame, it's...
Okay. Yeah, sesame in German, yeah. Great. So there's a consensus, right?
Yeah.
Can you tell us more about the consensus?
Yeah, definitely. So what we've been looking through the last years is that the concept of simulation is misunderstood by the majority of the healthcare professionals, and we know that many hospitals and countries are doing something about simulation. The universities are trying to introduce this methodology to their fields, but sometimes we don't have the support, sometimes we don't know actually what is clinical simulation. So what we've tried to do is to gather an amount of considerable experts around the world to say, this is clinical simulation, and this is the impact that they might have to the patients, but also to the healthcare professionals, and especially to the healthcare system. So I'm not sure if we can pass the next slide. So with the two societies, which was the SESAM and the American one, we gathered together with the leadership of Christine and Bob the opportunity to reunite at this moment 50 societies from different countries and more than 60 countries and institutions around the world that collaborate on organizing and doing this consensus. And this consensus is the base of every single person that would like to introduce simulation to their field. They can use this as an opportunity to show to their policymakers the needs and especially the impact that this can have on clinical safety and especially the quality of care.
Mm-hmm. And maybe more broad again, why do you think simulation is like a fundamental component in healthcare? Or why should it be also maybe, right?
Yeah, I see simulation as a service as any other that we need to have in our hospitals. So if you need a lab to run some blood tests, if you need to have an education department on your hospital, you also need to have a simulation environment or department in your hospital, because this is vital for your healthcare professionals to have the opportunity to produce these mistakes in a safe environment, the opportunity for them to make them conscious about the amount of good things and right things they do, because we always focus on the things that we do wrong. And it also is an opportunity to introduce simulation to patients. Sometimes they can understand and learn how to take care of themselves through simulation before doing to them. Probably they can also take decisions about some procedures that they are about to take. For example, if I have the criteria to have a heart machine-assisted, extracorporeal heart-assisted machine, Probably I need to understand what is living with this machine. Can I simulate this to the patient to make sure he's taking a right decision before going through surgery? We can do this, and simulation can help us. We can bring the patients, and on a safe container environment, we can do this, and they can try the therapy that he will carry on through his life and make the decision be more easier. And also we can use simulation to replicate some critical events and adverse events that we already had on our hospital to visit again, see what happens, and simulate the same process to take more notes and probably help us to take more actions and decisions through simulation.
Okay, very interesting. Maybe let's go to a specific example of how you can implement simulation. José, you have a lot of toys. We talked about toys earlier, but the good kind. Do you want to maybe elaborate, first of all, how do you justify in the context of all of these new things coming on the market and everyone being kind of overstimulated, how do you justify introducing VR specifically to the simulation trainings?
Yeah, that's a great question to start. In Badalona, we have different kind of 3 main lines of projects. They are divided in clinical care, education and training, and well-being or relaxation. But sometimes they are mixed together between themselves, because sometimes a project that is educational can be also relaxed in the case of the well-being for professional workers. How do I justify? Well, I think it's mainly 3 points. With VR for simulation, you have logistic and costs, because the cost of creating the whole materials and mannequins and preparation of the room for the actual simulation is very high, and it has to be in the same place always. So the cost to have one of these little machines that I can show off.
Yeah. You can also try it out later. We'll create a space.
I'll be around. But if you have everything that we need to have for a simulation inside this little machine, and you can bring it to any center. In the case of Badalona Serveis Assistencials, we have 18 centers all around the city. So we have over 1,400 professionals all around the city in different kind of work. It can be primary care, it can be the intermediate care, surgery, palliative care. So it's very complicated to have a simulation with different people from different centers and have it at the same time in the same place. What we normally have to still do for some cases. VR is good for some educational content, not for everything, any kind of technology. We have to know where to use it, what is it good for. It's very good for soft skills. When you talk of soft or hard skills, soft skills is mainly communication skills, decision-making, protocols learning, and hard skills are the technical skills. Like when you have to train for surgery or you have to train CPR, you need the muscle input to learn how much to push on the chest of a person. For that, we need a physical mannequin to be well-trained. So virtual reality is not for everything. The haptics is when you have these high-tech gloves that can make you feel like you're touching a virtual object, but we're still not there. The technology is not there yet. For soft skills, it's very good. You can train communication. You have your virtual patient. Like, we could do a whole simulation here in this empty space. That's what we do. If we go to the next, maybe in the next slide.
Yeah.
If you see the Resus VR is an emergency situation, clinical situations, and you see it's an empty room. I go to a primary care center. I bring the headset, I connect to the big screen, and I have like 5 students there, can be nurses or doctors, and each time they put on the headset, all the room transforms in an emergency room with a virtual patient that is reacting to their decisions. And it's very good, especially for first-time or training students or residents, because they are training to err, like Pedro said, in a virtual patient, not in a real patient. So it's a very good impact. So the logistic, the costs, and then the engagement. The engagement, when you present this new technology to healthcare providers that are used to do it in mannequins or with 2D screens, it makes them feel very stimulated to learn. It's like a game. As you said, it's a toy, okay. I don't like calling it a toy anymore because it's very useful for patient care. But for training, yeah, they still see a little bit as a toy because they're like playing a game and they are learning at the same time. And for the teachers itself, like myself, I'm a CPR trainer, so it's very good because they cannot look at the mobile or out of the window. They have to see what I want. So it's very good to concentrate their attention on the simulation.
Mm-hmm. Okay, so I would say that all sounds very easy and positive, right? What do you think are like the biggest barriers that you've encountered this far, especially when it comes to, you know, getting it accepted kind of as a training technique?
Yes, the acceptance, the resistance of technology is something very high in healthcare providers, as we talked before about that. But with anything that is new, an innovation is not technology, but when you do an innovation with technology, I can draw a parallel here. If anyone remembers when we first discovered fire, we don't, of course, but I'm sure a lot of people were resistant to use it because they were afraid of it or because they had a bad experience and they burned themselves with fire. It's the same thing with any technology. If you start using and you don't know how to use it, you can get harmed from that. So it's very important to teach them well, with time, how to use it and when to use it. And that was the other project, the Project Benestar. It was the first project I started with VR back in 2021. And it is directed to the healthcare providers. They were using VR for the first time themselves. And they were learning emotional management and mindfulness techniques. And at the same time, they were learning the potential of VR. And after that, we had a snowball effect, and all those professionals came back to me with ideas of how to use VR for patients. Like, oh, I could use this for the children that are afraid of having a vaccination. I can use this for the palliative care patients that are in a room for weeks or months and cannot go anywhere, so they can go to visit the pyramids or even the hometown. So they came back with a lot of very good ideas. Others not so good, but we have to filter what are really good or not. The costs are very much better now. If you think about 2 years ago, to have something like this, it would be like almost 2,000 euros, and now you can have one that's very good for 350 euros. So this is very more realistic, especially for public healthcare. I think I talked too much already.
No, don't worry. I think it's interesting. We haven't been interrupted from the audience at this point. Could you maybe tell us a little bit more, I think, about Project Benestar, right? Like, how can we also address what we kind of addressed in the prior panel, you know, like the also mental health of the healthcare workers? Because it's a tool. It sounds easy to use, but you know, like how can it maybe also be used for the healthcare work?
Yeah, well, it's good because the winner of the contest was in that line of work. Yeah. They are trying to find ways to treat the burnout, and this is a very good way because it was created specifically for healthcare settings when they don't have time, they don't have internet connection, so all the sessions are pre-recorded and uploaded in the headsets. You just have to turn it on, click on the app, and choose the session. So you follow the session 1 per week for 8 weeks. You can have the videos. The QR links are for the videos of the projects. After you try your own, because to teach mindfulness and emotional techniques, management techniques, is sometimes very difficult, especially if you are burnout. You cannot close your eyes and imagining a purifying light coming down your body. When one of them told me, when I close my eyes, I only see the fight that I have with a patient right now. So if you are in a relaxed environment, you are immediately transformed. And you see an avatar in front of you with a light going down the body, in each part of the body that the audio guide is talking about. That image is it's marked in your brain forever. You don't have to imagine it. So after that, you can use that technique, but you don't have to imagine it. You just have to remember. So we're talking now about neuroplasticity and making new connections and memories. So that's why the VR is very effective, because the immersion of the reality that you're living, it's like you're living that experience as it was real, because you are completely immersed there.
Okay, so anyone that wants to try that out later, you have to approach José and he'll give you that memory. Okay, let's go through a different type of example for simulation now. Carolina, you work with video recordings. So how is the quality of trauma care elevated through video recordings? And I think I might need a translation headset, actually. I'll just grab that one, because you're going to answer in Spanish. Yeah, okay. Just so I can respond at the end. Okay. Just go ahead.
Muchas gracias, Kira. Bueno, me gustaría agradecer también a la organización por
organizers for allowing me to participate on this panel with the rest of my colleagues with very interesting projects, but I hope that we can even get to some common projects related to what Kira was saying. Yes, actually, the patient's attention with a serious traumatism, especially critical trauma in an emergency situation, improves from several points of view. On the one hand, we can identify adverse events, especially we do an analysis which is centered on the addition of the initial care protocols for the patients, but we also implement measures in order to try to improve safety. And these types of measures are not only focused on the attention itself, but also in the work as a group of the team that takes care of that patient. In the image, as you can see, these are the video recording cameras that we have in the initial care box of the trauma patient, and this project comes from a research scholarship in 2010 with the Mafre Foundation. Initially, we implemented it in order to see the addition to the initial protocol to the care of the trauma patient. We work presently at a healthcare level, which is the process of all of the trauma patient care, the information of emergency services, the activation of the team, the transfer where the care of two simultaneous teams coincide, and all the stability care. And when that is not possible, we try to select the area where the patient needs to be referred to, be it the operating room, be it a scanner, be it an interventionist room. Obviously, this type of project, if you allow me, Kira, to go to the next slide, please, has allowed us to work. And we're right now in a working phase of our protocol of initial care. I don't know if you know, but our hospital presently is suffering several changes, such as, for instance, we're moving to a new center because we are making some architectural refurbishing, and that is a challenge for us because when this project is started, that has changed the patient's care. We've added even new devices, new points of care. In the initial care, therefore, the vision of our patients changes. Not only that, but as José said, the fact that we're just focusing on technical skills is somehow limiting us. And therefore, we want to also improve communication and an effective communication amongst the entire team. There's many tools described for these communication skills. The one that we're using presently is called TCA24, which is a tool that has been validated in pediatric traumatic patients in emergencies, that is based on leadership, appraisal, and communication skills of the initial care team, especially. TCA24. No doubt, if we keep this for the group that analyzes the video recordings, it is just limited. It's not good enough, so we try to export it with different types of feedback or briefing systems. Presently, we should make two analyses. One should be a on-site type of analysis, that is to say, with the patient, we do the analysis almost in real time, and this allows us to include professionals who are going through training, because we have a lot of training programs, both doctors but also residents, and we also do what we call a cold type of analysis, post-analysis. Once we have the data of the patients, once we know how they've evolved, once we have the quantitative data, we can see whether really we adhered to the protocol. Although sometimes seeing how the team faced an emergent situation is maybe a bit more limited.
Do you have more examples of how you could use video recordings? Outside of the trauma care, so maybe intensive care or other high-stakes settings?
Yes, maybe we could use it in other type of situations, for instance, emergencies or urgencies, and even in procedures which are more under control, such as, for instance, the operating room or other types of situations. A big part should mostly be focused on what we call a critical events analysis, that is to say, patients in extremist situation, for instance, heart stop, or surgical heart failure, or some surgical complex situations in emergency situations which have a high impact on the patient, a heart arrest, for instance, and a low incident that makes professionals maybe sometimes not be able to acquire the necessary skills. For instance, we've worked a lot on that. Kira, can we go to the next slide, please? We've worked a lot on different types of situations. One of them is, for instance, thoracotomy for resuscitation, a penetrating traumatism that affects, in this case, at a heart level, at a lung level. It is in extreme situations. And that started because we had a very high incidence of these cases for a short period of time, 2 months actually. That was triple than that of what we used to have in the past years. That made us work not only as a team, but also with other type of specialties, for instance, surgeons, heart surgeons, thoracic surgeons, and also in order to try to make professionals familiarized with devices which are complex. We have an example of a device which is called Reboa. If you don't know it, it's an aortic occlusion balloon that is placed in the aorta and blocks the bleeding. Abdominal trauma or pelvis trauma level. This is a procedure that requires some skills, and professionals did not feel comfortable with the use of this device. And we designed the stimulation scenarios based on video recording, and as José said, a recording in 360 degrees so as to be able to include the professional with virtual reality included in the simulation environment. Obviously, this improved the process, and this allowed for the professionals to minimize the stress or anxiety caused by these new devices.
Mm-hmm. Okay, as a German, if I hear video recording, I think data privacy, right? Professor Stamets already said earlier that in Germany we like to make things a little bit complicated. They don't like agreeing to being filmed, or all of the things that entail being on video. So maybe you could elaborate what are your views on the kind of ethical backgrounds of using video recordings and implementing them? Like, what are maybe the barriers? Do you have a German attitude also that you sometimes encounter where they're just like, no, I don't want to do this at all? Maybe.
posiblemente yo
Probably I would like to divide it into two levels. Number one, the patient level, and the other one, the professional, the healthcare professional. How do we try to do it? Well, in this case, this might represent different types of barriers, to be honest. At the level of the patient, most probably the first barrier would be privacy of data. Yes, we've talked about that. So I would tell them, if you want to implement this type of tool or device, please center yourselves, focus yourselves on the legislation that you have at a national level, but specifically at a local level in the different health centers. No doubt, our institutions, our healthcare institutions need to give us support, and we need to obviously adhere to the data protection law. But now when we're facing a situation of emergency, it's not the same as when we have an elective type of procedure, where we can ask the patient first if he or she wants it to be video recorded or not. So first, when, how, who needs to sign this type of consent in situations of emergency? It's very difficult. As a strategy, we try to include that into our informed consent in our UCI ward, so that all patients know that we are video recording their initial care. And if the patient at this point in time decides not to be recorded, we obviously eliminate the recording. We just delete it systematically. And not only that, but when we use it as a tool, as a simulation, or to export it and use it in training programs, later we ask for an express consent for that type of clinical case that the patient has to sign, so that he or she needs to know that it has not only been used in his or her care to improve the quality of the care, but also to be used in the training of professionals. It is true that the collection of videos need to be made very systematically. We use an analyzer, and that type of analyzer destroys and deletes systematically the recordings that have been made after 3 months approximately, so that those videos that are not analyzed are self-destroyed. That's a protection system for the patient. And on the other hand, we're talking about professionals. We try to generate an atmosphere of trust, safety. It's not as a punishment. The professional does not need to feel that he or she is being recorded, which might distort the attention. Or not only that, but we also try to respect as much as can be expected the professionals, so that they feel free. And if a professional says, no, I don't want you to record my actions, because obviously we analyze protocols, additions, and we also record errors, mistakes in the healthcare. So we need to be very cautious when we use those tools. And at the same time, we keep this tool alive in time after more than 10 years of its implementation, thanks to the generosity of the professionals and, above all, their great professionalism when they've been working.
Okay, I think I can imagine there being some questions about this at the end from the audience, but I think we'll move on for now. So we've had now different examples. In the beginning, we also talked about risk management. So now, Jennifer, I would like to come to your perspective, because you also work in a kind of related perspective on this. Maybe you could first tell us, the specific example of what you're working on, and then tell us what the challenges were that you found when you were implementing the technology, and obviously we now heard some direct examples, but give us the insurance and risk manager perspective on it.
Okay, so thank you for having us, because for Relyens it's so important to participate in this conference and show how important is strategic innovation. I think I have 2 slides for this. Okay, so how important is strategic innovation for the hospitals? And consider Relyens as a confident partner for the strategic innovation actions. So challenges, we have a lot, but we have just 6 minutes.
Yes,
yeah, 6 minutes.
A little bit more because we have.
So come on. We have the first step, that the context. The context today is so hard. We have problems with the human resources, with the well-being of the professionals, with the data. We have a huge data management. And also we have the adverse events as sinistrality. That's because we exist as an insurance company. So we have considered these 3 examples of projects. Hospital Universitario Puerta del Hierro de Majadahonda, Hospital Universitario de Fundación Jiménez Díaz y Hospital Universitario Virgen de la Rixaca as examples for the digital integration in 4 processes: anesthesiology, cardiac surgery, urology, and the digital integration of the general block surgery. So here we have the examples. The first step, most important, is the diagnosis. We have to consider how the organizations are working about this, how closely we could be to the professionals and the leader persons of these projects, and build this relationship based in confidence, integrity, and honesty also, because take decisions in healthcare is so difficult sometimes when you have a lot of innovations and news about it every day. So after this, we have context, diagnosis, we have the solutions and support. Monica told us before, our solutions in technology, we have care syntax, Clio. Now we have Amalfi solution with AI projects. It's quite amazing working here now. So in solution and support, we have to individualize and personalize to each organization the solutions we could offer. And think about also our investments are the investment of the hospitals. Prioritize actions sometimes is so difficult when you have a lot of problems every day, and you have to decide how it's really important for the organizations, for the patients, and for the professionals also. So our missions definitely is mitigate the impacts of incidents and the adverse events. So we have to configure these special solutions to the professionals and the teams. We have to train a lot the teams and apply the simulation. We have examples in checklist documentation. That's so hard in the hospitals, and with the surgery teams. The digital integration, the surgical procedure, and the objective to reduce the infection in surgery room, and the training and simulations also. So we have an integration workarounds. I could talk about this hours, but we have 6 minutes, okay? The team planification in hospitals, it's so difficult sometimes. We need be very closely to the team professionals to see the reality of the everyday and how it's going this planification with them. We have to work with multidisciplinary teams, and that could be an advantage because we have a lot of different profiles, biomedical engineers, and also healthcare professionals every day more motivated to study technology innovations and technology integration solutions also. And the leadership, it's a so important part for the successful projects. So we need really an honest leadership in the teams to solve the resistance of the change, that's a reality, and to think through the digitization dimension and to improve the culture of our auto-evaluations. So after this, we have context, diagnosis, solution support, and the change management. We present Relyens as a partner for the change management also, and to take the best decisions to the strategy innovations, to impulse the transformation, the competitive advantage of the organizations, and to think through the innovation-driven approach. So after this, the value-based solutions we offer are really, really important for our clients, for our teams also. And finally, we have 2 impacts. So in every beginning of the projects, we have to think about the impact and on how we want to measure this impact through the KPIs. So we invest a lot of time to decide with the professional teams how are the KPIs to consider and to measure the results and finally the impacts. I think that's the first answer. If we had more time, I can answer more.
Do you maybe want to talk a little bit more about the KPIs? Like, how do you measure the impact?
Yeah. So finally, the impacts. We have to center to the KPIs. These KPIs are important because we have to improve the results through the clinical perspective, through the operative perspective, and through the economical perspective also. This could be empower the teams and take the best solutions for the projects, and through the continuous improvement of the organization and for the team culture also. The data. So that's another reality. We have not a lot of data every day in the hospitals. We have to manage this data with ethical compromise and with new tools that we could make easy every day for us as a professional in healthcare. Through pictures, through analysis, through recording also, and through the patient signs in real life. That could improve the quality of the assistance and could integrate the mentality in healthcare professionals to the mentality in the technology solutions. We could diminish the variability in processes through automatic pathways, through optimize the researchers, and through optimize the event adverse documentation also. We improve the safe culture of the patients, and we improve also the team communication. That's one of the reasons of the beginning of the problems sometimes with the events adverse and all of these incidents. And finally, we have to think about the KPIs to the benchmarking with other organizations. That's quite important today because we have the competency, we have a lot of centers dedicated to healthcare and a lot of patients to decide and to decide how the continuous improvement, how it's going to be. So I think it's all. Little actions, small actions to big changes here.
Okay, and maybe to also come back to some points we talked about earlier, how do you experience kind of the reaction to implementing projects like this? Because you're also close to the process. So
yes. So our know-how and our expertise in insurance, dedicated to sinistrality and adverse events, show us that it's today too much difficult sometimes react to the change management from top to down and down to top also. So we have to work very closely to the directors of the hospitals, the general directors of the organizations, and also with the teams to work on it and make this confidence to implement the digital solutions and to see the results and the future of all of this.
Okay, thank you very much. I want to also address, we had a little bit more time for the individual questions because sadly Juan Antonio Marques couldn't be here because he works out of Valencia, and obviously with the rains and the floodings, he was incapable of coming here today. But maybe he's watching in the live stream. Who knows? If he is, send us a sign. Okay, so I think everyone had a chance to say something? Good. I want to give the audience a chance to also still ask some questions before we get lunch. So I hope we will still get some questions. Yeah, there's a question up there.
Well, thank you. My name is Eske Osvang. I'm professor of anesthesiology from Copenhagen, working with AI in patient monitoring. So one of our projects is actually about monitoring the staff, how stressed they are and so on. And this brings me to my question, because I think one of the future issues we have is how to teach our younger colleagues not to do things. How do we talk about stopping cancer treatment? How do we talk about not doing surgery? Because that is one of the best ways to prohibit complications after surgery, is not to operate. So any thoughts about simulation on the hard discussion, the hard talk with the patient? Difficult talk, sorry.
I think he was looking at you.
Yes.
Communication skills. Yeah. Talking to the patient. You can use you don't even need the VR glasses. You can do that in a 2D screen with animated avatar. If you combine it with AI, a regulated AI and very well prompt, you can make an AI patient with the right information and the right personality for that simulation. So you can have a situation where you have to give a bad news to a patient or to a family, and then you have to decide what you're going to say, and then you're going to have a direct impact on those virtual patients. That's going to be realistic because you can talk to them, they can talk back to you. It's not like you have to push a button. It doesn't feel like it's not real. You're really feeling that sensation. So you can do that over and over again, and then you're going to have feedback from that same simulation on how well did you perform. If you were looking at the patient, if you were saying the right things. So you are actually training very basic and very advanced at the same time communication skills with these techniques, with these elements.
Well, I think that's great also because there are definitely people who I wouldn't like to talk to my relatives, for instance, because I know they don't have very good human skills. They might be excellent surgeons, for instance, but they don't have very good human skills. So do you anyway see that you have to pass a bar in order to be allowed to have that discussion?
I'm not sure. I'm not sure I got the question.
No, I mean, should everybody be allowed? Should everybody be allowed to operate? Yes or no? That's easy to answer. And should everybody be allowed to talk to patients? Sorry.
Okay, that's a deeper conversation.
Yes.
Well, if anyone should be allowed to be a doctor, that's I think the basic question. There's no evaluation before they enter the grades to enter medical school, for instance. And that could be a problem in the future, of course.
But you can be a radiologist or you can be a whatever, where you don't see patients.
Yeah, empathy is very hard to teach. I'm also a tutor of residents, family medicine, and some of them really are very smart people and very intelligent, and they have a lot of knowledge, but they have no social skills sometimes because they are not used to talk to people in general. So that's very hard to teach. And I think this can help because they can really get in a very stressful situation because of the response of the avatar before they have to do that with a real person and damage the person forever. If they give a bad news in a way that's going to be damaging for the family or the patient itself, it cannot really go back. You cannot undo that damage. But if you do that with a virtual patient, you can do it again and again until hopefully you learn how to do it better.
Thank you. Thank you. Good question. Answer, sorry.
Good question, yeah. Okay, do we have any other questions from the audience? Now's your chance. You can also approach the speakers, obviously. Maybe not while they're eating at lunch, but afterwards.
I think we have
everybody.
Yeah? Yeah, down here.
Hi. It is working? Okay. Thank you for all your presentations. So I wanted to ask you, regarding the staff being welcoming towards themselves being recorded and then having like conversations about it, how did you build a safe environment so that people were willing to learn from their mistakes, and how did you work on that so they would be willing to be recorded and then have other people see their mistakes as well?
Well, we might think otherwise, but actually the answer of all the team members of healthcare and the rest of the workers at the ICU gave us an excellent response. They all said yes. Actually, we didn't have to persuade them or twist their elbow to try to convince them that video recording would be essential and that you may learn from your own mistakes. We didn't need to convince them that it was possible. It was already perceived by them as positive. This is probably from very old work. We've been working a lot at the ICU in safety patient strategies. There is a culture level of safety very high, so the professionals accepted the tool and we didn't need to convince them or persuade them specifically, no. We didn't need to emphasize. It was easy to convince them. And it is true that we do have an analysis, as I said before, not immediately, but afterwards. It's a special group that analyzes the video recordings. Then we have a multidisciplinary professional that carries out a systematic analysis. It is time-consuming and tedious, and it requires training to be able to perform it, but it's open so that any professional that wants to join or participate in any recording or reviewing has the freedom to participate and may join in at any moment. And so that they see the freedom, the openness, the transparency, and that if they want to, may participate, sometimes actively or even indirectly. It does allow for confidence, and therefore the implementation was better.
Mm-hmm. Yep. Sorry.
We've had the same experience, you know, implementing the video recording for training purposes. So I can tell you that the professionals would tell us that it was very good for self-assessment. To watch themselves in the video recordings, it was essential to self-assess. So instead of being a barrier, they actually welcome it. They like to watch themselves so as to improve by themselves their own procedures and techniques. You know, talking about those who were actively engaging in those projects, the professionals were positively admitting to video recording, willing to be recording. We also had with students and residents, older residents who already assist in surgical procedures, very, very useful. And for resident tutors, so that they can tape the residents or the students and show them the results, the outcome of their own intervention, possible errors, how they perform, and for training purposes, that has been very well received, very positive, as considered by everybody. So you have to talk to the professionals who were actively involved in the projects and to clarify the ends for which we are taping. We're taping for this and that purpose.
Okay, thank you. Let's see, we have 1 minute left before lunch. Yep, up there. We still have 2. Maybe we can, or 3.
Yeah.
Okay. Well, no lunch for you guys. Now Mirka is gonna at some point force us to quit. Yeah. One more. Okay.
Hello. I'm Frédéric Mail from AMA Insurance from Belgium. I have just a small personal situation, and I want to be able to tell it. Yesterday, I flew from Brussels to Madrid. When I arrived in Madrid, my phone was blowing off because my sister tried to tell me that my dad is dying. He's currently in a hospital in France, and she has understood that he's going to die in the coming days. So I say, okay, let's see what are the facts. I try to contact the nurse and so on. And what happens at the end of the day, it was very emotional, intensive afternoon. What happens is that one nurse speaks to another night nurse, who speaks to another day nurse, and in this process, information comes from doctors needs to say something to doctors, is going to give some bad news, so you need to be there. I mean, people may mistake that's what we speak about it. The information was not correctly transmitted. At the end of the day, it has an impact on me and my family. My question is, if this kind of things happens and it has no impact of the patient, how can I trust that something else is going to happen that might have an impact on my father? And how can technology help to minimize those kind of incidents?
I mean, that's, first of all, sorry that you had to go through that.
Yeah.
Sounds like a nightmare, kind of the thing we are all working to avoid. So it's always sad to see it happen in real time.
Well, the problem with communication there is not only the communication skills. I think it's more the organization of between the different persons and level of care. And the contact, of course, it was more complicated because you're far away. But it can happen. It can happen even with people there at the hospital sometimes.
Yeah.
It's these kind of cases that are important to be seen with a microscope and study why does it happen and how can we change it. And of course, simulation is not only for the communication skills directly, but also for the organization or to see why it's not working, where is it failing.
Yeah.
And I think the work you do in the companies is important for that, because then you can diagnose where is the problem of the system. And I think cases, it's very important that you tell them that happened, because then they will look into it and they can learn, and then it won't happen again.
Maybe because of this, now the patient is more implicated in the patient safety also. And what we are seeing now in different organizations, it's in this kind of committees of the following of the event affairs, are more patients on it. And the decision and the level of decision is more and more important in the organizations.
Can I just add a small tip that it happened quite the same with me, and my family member at the end she died, and I ruined the committee of this hospital, which is one of that I didn't work, and I worked with them to know a little bit more how and what could we do to avoid this kind of situations, because they didn't recognize the importance. So from that very first day, I understood that even we as healthcare professionals, when we pass through the other line, when we are patients and families, we still have a mission for our colleagues when we are patients and families, and we can help them a lot to recognize. And nowadays, this case, what happened with my family member, now it's a simulation case for my students, and I use it. And it helped them a lot to recognize this kind of situation. So it's very sad, the situation, but it's the main way that we try to find what we can get the most of the case and avoid to happen it again. So it's another kind of strategy we can use, definitely.
Okay. We had at least two more hands. Yeah, someone already has a microphone. Okay.
I have a microphone.
Go ahead.
Hi, I'm Daniel Arnal from Madrid, Hospital Universitario Fundación Alcorcón. My question is to Dr. Mudarra about the recording. This is quite controversial, and whether if you are doing this through an investigation, through an investigation committee allowance, or is more as part of the clinical record of the patient. If it would be the second point, and eventually this could be something that might be extended and seen as useful, would the patient, I believe, and I would like to know your opinion, whether the patient should have access to the recordings, because it's part of, eventually, of the medical record. It could be, as we do an anamnesis or whatever, and it could be useful for the patient and for the family eventually, in case something goes eventually wrong, to see how the patient was treated and how the team cared for his relative and eventually could be even healthy for getting to the bad news if that would happen. If not, it would be just a right to have your own image. Are you doing this? Are you planning to do this?
Very interesting and relevant question. Undoubtedly, we need to work further right now in integrating the patient and also even the family member in the decision-making process. There's increasing evidence as to the benefits of that. We haven't had an experience that either the patient or the family members have expressed a wish to see the recording of the patient or their family member. If they ever express that wish, of course we will provide access freely. If a patient or a family wants to see the scanner or the X-ray, if a patient comes with a brain injury with a poor evolution, we offer if they wish to visualize the neuroimaging. So no, we haven't actually had the situation. It is not integrated as a part of the clinical record, no. We want to have an adequate management of the patient, but we just adhere to the protocols that we have on initial care and emergency care. Probably we shall have to work on that in the future. And as I was saying in the other question, we'll probably have to bring the families on board and integrate them so that they can have direct information, even real-time information of the situation of the relative and loved one, so that we can minimize those situations of anxiety and distress. Our experience where we try to integrate the family in the decision-making or the emergency decisions when a patient has been limited in some way or another has been a very positive experience. The family understands information better, and undoubtedly we shall have to advance on this issue.
Yep, I know. We're not allowed to continue. Rika. You can grab a mic, or yeah. Should we just leave?
Yes. No. Well, yes. I'm very sorry to stop your super interesting session and discussion, but it's just to move your discussion to another room so that you can enjoy and continue, asking your question, networking, and by eating lunch. But just before you go, just one little house rules for the afternoon. So in the afternoon we have the split program. We will have running, as we said already before, we are running in parallel to this room, which will be still translated from English to Spanish. We have workshop rooms, 2 workshops, running in parallel with only English language, so there won't be any translations. There is no need to register or, you just need to come to the room, but the space is limited, so there is not a lot of seats. It's a little bit tricky to find them. So I hope we won't lose you. So I need to find it by myself still. So take your time to enjoy lunch and then try to be on time also for the workshops and then here back at the lectures. Thank you very much.